In general, chest x-rays are under the umbrella of what you call imaging, because the chest x-ray is the basic, most common way to look at what's going inside of the chest, to see any disturbances. But then if there's anything that needs further attention, CAT scans are very popular. One can do MRIs for a little bit more in-depth look and to see like if there's been metastasis from lung cancer, for a variety of reasons, for a good looking at vessels as well. Nowadays, there's also different imaging studies called PET scans, and that's to look at infection as well as cancer. And then what's becoming even more popular is something called ultrasound. So that's just right at the bedside, and that's being able to look and distinguish between fluid or air right there in at the bedside. So it's like an instant way to look and see what's going on inside the chest. So a chest x-ray is produced by x-ray beams passing through the thorax and exposing a photographic plate or film. So radiographic imaging is based on the anatomy of a patient blocking those x-ray transmissions caused by the degree of exposure of the photographic plate. So different terms that you guys really need to be aware of are radiolucent, and that's where there's minimal tissue density, air or air-filled structures. So it appears as blacker areas. So radiolucent turns black, and that means air. Radio-opaque is an area or body tissue that cannot be penetrated, so it's thicker, and then it'll produce a white area. Okay, so I like to remember radio-opaque is as there's opals. You know, opals appear as white, so opaque, opals. So radiolucent, air, black. Radio-opaque, white, and that's tissue, body tissue in the lungs that can indicate atelectasis, fluid, anything that's not air. And then radiodensity just talks about the relative ability of an object to absorb x-rays. So yeah, like air would be more radiodense than say a bone. Okay, so there are 4 basic radiodensities. Gas appears black or radiolucent. Fat will appear gray or less radiolucent than air. Bones or metal appears all white or radio-opaque. So you could see what we call foreign bodies, like endotracheal tubes, catheters, any type of calcium deposits. Catheters could be, you know, the NG catheters, nasogastric. It could also be like if a patient needs to get a chest tube, that would be a catheter, anything like that. And then soft tissue, such as water, can appear gray or less radiolucent or whiter. That would be like heart, blood vessels, muscles, you know, anything like that that can't absorb as much. So the different views that one could see and what's most common. So I don't know if anybody has ever gone into their doctor because they have bronchitis or whatnot. They would get, the standard view would be a PA and lateral. So posterior anterior means from back to front. So you would stand up against the plate, and the picture would be taken from your back and go through your front. So that's the most common. So that's called posterior anterior PA. AP then is from front to back. So this view is not the standard view, and it's not as common. However, this is the most common for patients that are non-mobile, they're immobile. So patients in the intensive care unit, so the ones we would see a lot of times that are intubated, this is where the X-ray technician would come up to the patient's bed, put a photograph, or the film itself, under the patient, and it would go from the front to the back. Okay, so PA and AP are different. If you're mobile, and you can get you would do the PA and lateral, which is the most common, but AP is what we tend to see a lot in the intensive care unit for patients that are immobile. Laterally just means through the chest, so from the side. Obliquely just also means through the chest at a different angle, and then lateral decubitus is where the patient lays down on their side. So there's indications for each one of these, but once again, the most common is PA and lateral. So when you're looking at a chest x-ray, we need to make sure that the patient is in a proper position. So the patient should not be rotated to one side or the other. And you can tell that by looking at the patient's clavicles. They should appear symmetrical. And then the radiograph should be taken at full inspiration. And that's, and why is because the chest x-ray is always exposed in deep inspiration so that more lung fields are visualized, because they're obviously filled up. In deep inspiration, the diaphragm is at the level between the 8th and the 10th rib. So looking at the chest x-ray, it's when you're looking at the frontal view, remember, we're in anatomical position, so the patient's left is your right. Okay, so just remember that you're looking at the patient's anatomical position. So the trachea, vertical radiolucent structure between the clavicles and over the spine, so it's directly in front. Carina, which is where the bifurcation of the left and right main stem bronchi, that's located at T4, so meaning thoracic vertebra number 4. There should be 12 pairs of symmetric ribs. The right hemidiaphragm is higher than the left because the liver sits on the right side, so it just pushes up the right diaphragm. The costophrenic angles should appear sharp, and costophrenic angles are right there where it's just the very bottom angle of the ribs. I'll show it to you. The mediastinum should be narrow, the cardiac silhouette should be apparent, and the heart, of course, will be on the left side, and you will be able to visualize the aortic arch. So I did just add this one picture in because I just kind of like to look at thoracic anatomy, and then we'll start looking at them from the x-rays. So starting at the top, the thyroid cartilage is the big cartilage we see here. We also call it the Adam's apple, thyroid gland. Under that starts the trachea, and then we have the sternum, the manubrium, the body, and the xiphoid process. Here are our clavicles. Okay, and here's our acromion process. Here's all of our ribs, 1, 2, 3, 4, 5, 6, 7, 8, 9, 10. And then, of course, down here, the false ribs are all the way down. Here's our, okay, we already said that. The dome of the diaphragm, you guys can see that. So if you look at this outline, here's the left side, and of course the right side. And that's once again because the liver is pushing up on the right side. And here's our humerus, border of the left ventricle from the heart. Okay, so we'll keep going. So here is a normal chest x-ray. The top is kind of cut off, but that's okay. So here you can see the clavicles, so you can identify if your patient is in a symmetrical position. You can see your aortic arch. Here's the left lung and the right lung. Here is the base and the apex of the heart. Here is the top of the diaphragm. Now these costophrenic angles are cut off. So we'll look at a better image where you can see the costophrenic angle, which is supposed to be down here. And here's the different ribs. So here's the varying ribs that we see. So here's another normal frontal chest x-ray. So we're looking at pulmonary anatomy. Many pulmonary conditions can be diagnosed by a chest radiograph. On a PA chest radiograph, look at the heart and mediastinum shadows. So once again, this is the PA, posterior to anterior. And you're going to notice the heart is in normal size range. So the one thing when you do have an AP, an anterior posterior, the heart will always appear as larger than it is because it's in the photograph first, so it's distorted. Okay, so here's a great picture of the trachea. Okay, and you can, if you guys can see this mark here, and this is approximately T4, this is where you can see the left and the right main stem bronchi coming down. This knob here is the aortic arch. Here's the heart contour. Here's different lung markings, and it's really important that we see different markings in the lung. Here's the diaphragm, and here's a good picture of the costophrenic angles. Okay. And then here is the pleural space, or the pleura itself. Okay, here's normal female chest x-ray. It's a little bit hard to see here. Here's the spinal process, the aortic knob. Okay, here's the hilar region. And remember the hilar region, Big, how can you tell if that person has an enlarged heart? Okay, very good question. So first of all, this, I don't know if this is a PA or an AP film, but the heart should not appear greater than 50% of the whole thoracic diameter. So if you're looking at the diameter here of the chest, you can't, the heart cannot be 50%. So this heart actually does not look big, believe it or not. So I can show you guys some ones with CHF, cardiomegaly, and they're huge. Okay, here's another one. And we know this is a female. Let's just all get it out there and giggle. Okay, here's breast tissue. Okay, so here, this is a really good picture. Okay, this is a really good picture of a chest x-ray. So let's kind of start from the top. So I always kind of like to start with the airway. So I can see that the airway right here, the trachea, is symmetrical. I'm going to look and see at the patient's positioning. So I'm going to look at the bones, and I can see here that the clavicles are symmetrical. So the patient looks like they're in good positioning. I'm also going to look at the ribs. Okay, and everything looks normal here with the ribs. I'm going to look at the heart. So here's the cardiac silhouette. Here's the aortic knob, the left ventricle. The heart looks like it's in good position. I'm going to look at the diaphragm. So I do see a nice diaphragm. The right side is a little bit higher than the left, but I do see nice costophrenic angles right here. Okay, and now what I'm going to look at is the lungs themselves. So I'm looking at the lung parenchyma, and I'm looking symmetrical. I see symmetrical lung markings and radiolucent air. I can see where the hilar region is here, and I can see the vascular markings. So the blood vessels themselves, as well as the airways coming into the lungs themselves. And it looks like there's equal amount of air on both sides. So this would be a normal chest x-ray. So here we have essentially a normal chest x-ray in a 50-year-old male, and this is the PA view, and this is the lateral view. There is a degree in this person of hyperinflation, and that's evidenced by both the increase in the retrosternal space. So retrosternal, you guys can see right here, and this is one finding on a lateral chest x-ray that right behind the sternum here, there's more air than there should be. Okay, so this is what's what we call a retrosternal airspace, and somewhat flattened diaphragm here. So it's just really radiolucent or really black filled with air. So this person we could say this person has a little bit of air trapping. So can anybody tell me if someone has some air trapping, what we could, what might we think about with air trapping? Do you think it's processes? Like, do you think this would be asthma? Do you think this might be COVID? Do you think this might be pneumonia, tuberculosis, lung cancer, cystic fibrosis? What do you think?
It would be COPD.
Good. Good. So yeah, I see pneumonia. I don't see pneumonia because I don't see anything that would be focal, and we'll get to that. But yeah, when we have air trapping, that indicates an obstructive lung disease. So COPD would be a good answer for this one.
Hey, Jamie.
Yes.
When you started saying that, I don't know if other people could hear, but you were pretty muted for a second.
Oh, you know what? I turned my head. You're right. So, yeah. So, is that better, Dusty, and everybody?
Yeah.
Okay, good. Okay, sorry. If I turned my head, I don't have my external microphone on, so you're right. Just yell at me if I do turn my head, and don't talk into the laptop. So thank you. So what I was just talking about and asking was, if you're looking at this, you do see a patient that's pretty darn has lungs that are pretty darn radiolucent, so meaning lots of air, and these just look like big lungs. So I just kind of asked what pathologies or what condition this you could think about. So when you hear air trapping and larger radiolucent lungs, you're thinking of an obstructive disorder. So you're thinking of COPD. Okay. This could be an asthma exacerbation. You don't know. It definitely could be. But we know that there's some sort of obstructive component. And when we talk about different disease processes, and we're today talking about imaging, and then later for cardio A&P, we're going to talk about pulmonary function testing. And just because there's patterns that can be suggestive of a disease, but we don't really know exactly what disease that is. So one of the things I really want you guys to think about is just differentiating between obstructive and restrictive diseases. So an obstruction is where, once again, you have normal compliance and you can get all the air in, but generally the airways tend to collapse on exhalation. So you get airflow limitation leaving when you're trying to exhale. So think about that both when it comes to imaging, when it comes to pulmonary function testing, whereas a restrictive component such as pneumonia, atelectasis, ARDS, that's where the lungs are becoming stiffer. A lot of times they fill with fluid and it's harder to get the air in, and that will appear as more radio opaque, so less air in. Does that make a little bit of sense? Okay, so one of the things this image shows up, I think, is absolutely perfect is look at the trachea. You can really see that airway, and you can see the symmetrical lining of the trachea. And what I think is really good here is the carina. Can you guys all see where the left and right main stem bronchi branch off of each other? Okay, right here. Okay, so that's a really good picture of the airway, I think.
Is that trachea shifted to the left a little bit?
No, I think it looks pretty darn symmetrical.
Okay.
And I can, if I don't have one in here, I can show you some shifting of the trachea. So you guys, anytime if you're seeing a trachea or the whole mediastinal cavity, sometimes you'll see the whole cavity shifted. Air, when there's air outside of the lungs in the pleural space, that will shift the trachea away. So say if it's on the right side, it would push the trachea to the left. Same with a massive amount of fluid. So a large pleural effusion would do the same thing. It would push the trachea away. So the opposite is true if you have atelectasis. So if you do have like major atelectasis on the right side, it would pull the trachea towards the right side. So a trachea will be shifted away from extra air, and when there's not enough air in the lungs, it'll pull the trachea towards the affected side. Okay, so here we see a chest X-ray with a pleural effusion on the left. Okay, so you guys can see this. Now, we just talked about that. So what do you guys see this trachea? It's very shifted to which side?
The right side.
Yeah, very good. Very good. And how do you know this is a pleural effusion? Because all you see is a big radio opaque area right here. So when we said radio opaque, that means there's not air. So that could be fluid, that could be just a consolidation, it could be atelectasis. It just means it's not air, right? However, when you see it, if you can see this, have you guys, when you were in your chemistry or your bio 111 or whatnot, you had almost like a meniscus sign. And a meniscus sign means you can see almost like a little water marking. So we would assume this patient would have a pleural effusion if all of this down here, so the pleural effusions, it's extra fluid, so they have a gravitational pull to the bottom, and you can see this meniscus sign, and so you have a good indication that this is water. So there's a couple of things you could do. So if you would do what's called a lateral decubitus, that means you would lay a patient on their side, you would see all of the fluid shift to the bottom, and so you'd see all of this air. I'm sorry, you would see all of this side blunted with fluid. So that's one way. Another way you could do this is where a bedside ultrasound, if you put that right on the patient's chest, that extra fluid would interfere with the sounds. And so you could say, oh, there's fluid in there. Okay, so what do you guys think this patient would need as a hold on, I saw a question. Go back to the question. Where did the question go? Oh boy. Okay, go to my chat box. Info message. Sorry, I missed that question and I can't get back to it. So you can
Hey, Jay, I was
Yes.
asking with all
Yes.
that, does it matter which side the patient lays on?
Correct. Yes, it does. So because we would suspect that the pleural effusion is on the left side, you would lay them on the left side.
Okay.
Yeah, good question. Okay, and so if this patient had this large pleural effusion, clinical effects you would see is if you look there, that's a good half of the left lung. So a quarter of their lung is unable to exchange gas. So you would see a lot of hypoxemia with this patient, and maybe even some difficulty ventilating, really trying to get that CO2 out and bring more oxygen in. So this patient would have respiratory compromise. And so this patient, what do you think we could do for this patient? Chest tube, exactly. Yep. So this is where if this patient was in your unit, they were brought in, you put them on oxygen, okay? You put them on a lot of oxygen and then they're still having problems. This is where you guys would help out with conscious sedation. So this is where you might put the patient on the capnography, and then the doctor will sedate the patient and put a chest tube into the posterior side of their thoracic cavity to drain all of that extra fluid. Good. Okay. Now this is an abnormal chest X-ray looking at a right-sided pneumothorax. And the reason why you notice that is because Here you're saying, oh, good. At first look, at first glance, you might say, oh, this is great. The patient has a lot of nice air in their lungs. Well, it doesn't. The left side and the right side do not look symmetrical. And all you see is a radiolucent image here. You don't see any of these vascular and airway markings on this side. Okay, so this is a really bad, what we would call a tension pneumothorax. So this is where, for some reason, air leaks out of the lung parenchyma and fills up the pleural space. So all of this is air in the pleural space. This here is most likely the lung. Okay, what do you think the patient's clinical condition would show?
Is that like a collapsed lung?
Yes, this is definitely a collapsed lung. So this patient would, one, be in pain. Number two would be really hypoxemic. They would have dyspnea, meaning they would be having a hard time ventilating. So they would have retractions, they would be tachypnic, they may be nasal flaring. Their saturations would be low. If you got an ABG, if you had time, if you got an ABG, it would most likely show a respiratory acidosis if it's been going on for a little bit. So what do you think this patient would need?
Needle D.
Yes, that's right. So they would first need to have needle decompression, where when you're compressing air out, you would put a needle right on the anterior portion of the chest. Now, if there was a lot of it, which this one probably is, they would also need to have a chest tube. Okay, they would need a chest tube on the right side. Very good. Okay, so if you're looking at this one, boy, you're seeing some problems, okay? So the airway, it is shifted to the right some, right down here, okay? You're seeing the clavicles look pretty symmetrical. Oh boy, do you see some problems right here? It looks to me like those ribs are broken. Okay, so we can say, oh, there's probably been some sort of trauma happening. The heart is pretty large. Okay, the diaphragms, you are not seeing a good costophrenic angle here. And you're seeing something here and something here in the lung parenchyma. So this patient has quite a bit of problems, okay? So first of all, we're seeing a broken rib. It looks like this is probably some sort of contusion here, okay? That's probably a pneumothorax, okay, here. And then over here on this side, we're seeing some sort of consolidation. So that could be, that could be a pneumonia process, that could be some fluid. This could be a pulmonary contusion here, atelectasis, and then we're not seeing good expansion with the lungs, okay? So this is a pretty bad hypoinflated. So this patient, once again, would be hypoxemic, showing signs of respiratory distress. And this patient will probably need a lot of therapy. So this patient will probably need to be intubated and get all of this. Now, looking at this chest X-ray, could you tell the difference if this is atelectasis or pneumonia? Could you or fluid here? Could you guys really tell? You would not be able to tell exactly what was going on, so they would need to have further investigation. So either either a CAT scan. Or they would need to have a lung ultrasound to confirm that this is probably some sort of a focal consolidation. Now, why do you guys not think this is a pleural effusion right here?
Because then it would be black, right?
Well, a pleural effusion would be radio opaque white, but would you think it would be right in the middle if it was fluid from buildup in the pleural space, do you think it would be right in the middle of the lung?
You said it would be at the bottom because the gravity is taking the liquid down, right?
Correct. That's right. So I would think this is like a focal pneumonia or an atelectasis. I don't think this would be a pleural effusion, or I don't think this would be pulmonary edema. So interstitial fluid leaking out of the vascular spaces, and we'll get to the reasons why on that as well. Okay, so looking right here, this patient also has some issues. Now, the one thing we do know about this chest x-ray is a couple of things. One, this is an AP, okay? And the reason why we know that is because the patient has this little line right here in their trachea. So this person has an endotracheal tube right here. So we know this person is supine. Okay, so it's looking at the anterior to posterior. So as I said, this can distort the heart. Okay, so you can see the heart looks a lot bigger from the anterior posterior side. Okay, clavicles look symmetrical. I don't see any broken ribs. Cardiac looks big. The diaphragm is blunted down here. The costophrenic angle is blunted on the left side. Not so, well, yeah, a little bit blunted on the right side as well. Now think about the inspiration here. Is this patient fully getting a good inspiration? So in other words, are they fully expanded to the way they should be? I would definitely say no. Very good. Okay, so this patient is hypoinflated. They're ventilated. We see a lot of congestion right here in the hilar region, meaning there's probably some extra fluid here. Okay, this patient looks like, I don't know exactly what's going on, I don't know their history, but this patient does have hypoinflation, most likely from some sort of restrictive component. Okay, good. Okay, now here is a patient that's also intubated, and here you can see a correctly positioned endotracheal tube, and the tip is approximately 5 centimeters above the carina, and this is a really good image. I don't know if you guys can see it, but right here is the carina. So here's where the left and right main stem bronchi branch off. And the endotracheal tube just sits right above that so that when you put in positive pressure, it will get to both lungs. Okay, now this patient also is hypoinflated. Okay, so this, and it's on both sides. So I might think about, and you guys see all the little white markings throughout both sides? My guess is this patient probably has pulmonary edema. Okay, so fluid that leaks into the out of the vessels and leaks into the interstitial spaces. And when it does that, what's right from a pulmonary standpoint, what's right by the interstitial spaces are the lung parenchyma. So fluid moved into these lungs and are not allowing air. So they're as much as there should, so that diffusion will definitely be disrupted. So this patient's intubated, of course, so they're probably getting lots of diuretics. They're also getting good proper ventilation to help with the ventilation status. Okay, now there's a big problem on this one. So when you put a breathing tube in, and we kind of looked at that a little bit, here is the carina. This is where the patient got their breathing tube when they were getting it put in. It got inserted into the right main stem. So now the right lung is receiving ventilation, but how about the left lung? Nothing, okay? So that'll cause a lot of problems. That's called a right main stem intubation. So this is very important as a respiratory therapist. This is one of your main jobs is after the patient gets intubated, run over and look at the chest x-ray and say, oops, I better pull the breathing tube back. And so you need to position the breathing tube where it's supposed to go. Okay, so there is this website. So if you click on it, learningradiology.com, there's lots of them. So it just has a lot of different chest x-rays and different imagings that you can look at. So let me get back to where I was. Here we go. And so, yeah, looking for different views, anterior, posterior, posterior, interior, lateral, lateral decubitus, and oblique ones. So any questions on that?
I don't think I'm very good at like reading an X-ray.
Well, that's because you just learned it. So they do take a while, and the more you keep practicing, the better.
Mm-hmm.
So what I want for you guys to do is just to keep practicing and to take a look at Google. Google, if you go to Google, click on pneumonia chest x-ray and images. They have so many nice images. And then in our lab, we actually do still have the old-fashioned readers, which is kind of fun. Nowadays, when you look at the images, they will be digital, like we just looked at. And so it's nice to see them on the computer. However, they do still produce them, and a lot of times physicians will go down and still do chest x-ray rounds down in radiology, looking at the machines that are similar to what we see in our lab.
Jamie, just a question on
Sure.
talking about examination of the chest. I was just a little bit confused about like when he says the patient's left is your right.
Yes. Okay.
Can you clarify that a little bit?
Yeah, good question. That just means that you're looking at the patient in anatomical position. And so here, let me share this. Let me pull this up. I'll share my screen again here. Is that now? Okay. Okay, so we'll look at this. There we go. So when you're looking at it, you're going to say, oh, well, this is my left and my right. However, you have to remember that you're looking at the patient's anatomical. And so this is the patient's left side, and this is the patient's right side. Yeah.
That's what I thought, and I was like,
yes. Yep. No, you need to clarify. That's good. And it's good because a lot of times the radiology techs will actually, like you can see right here, there's a little label. So a lot of times they'll have a label that would say left and that would say right over on this side.
Jamie, I had an A&P professor. I don't know if this will help anybody, but just basically think of these x-rays, the person looking back at you.
Yes, exactly. Okay, so here. No. Okay, so let's look here, and then you'll see all the different, so this is a good one. Here you can see that there's a pneumonia process in the left side. Okay, so this one's good. It says PA standing. So that's really good when it has the view. So, you know, a posterior, anterior. Okay, so here's also, and see, Emily, how this one's labeled. So it'll, you know, you'll be able to be like, you'll just confirm, be like, oh, good, this one's labeled. So here's a PA and a lateral. Okay, this is a nice one. So it kind of can tell you a lot of different, can show you a lot of different examples. So here's lobar consolidation. So you guys, when you're thinking of like a pneumonia process, it's generally focal, okay? Whereas if you look at, whoops, I didn't want to go all the way back. Whereas if you looked at, okay, whatever. Yeah, that's a good picture there. So if you look at it, a consolidation will be in one area, okay? Whereas if you have something that, take for example, like congestive heart failure that leads to pulmonary edema, it would be on both sides, okay? And here's a picture of atelectasis, so just collapse of lung. Here is a nodule, they're smaller, and here's a larger mass. How would you guys know, like, what other techniques do you think that oh, you guys can't see this. I'm sorry. Sorry, I flipped over to this one. Oh, there we go. That's what I was looking at. So this is kind of a good picture of a consolidation. Interstitial just means it'll be all over the lung parenchyma. So a nodule versus a mass. What else do you think that to continue to look to see, like, what is this nodule and what is this mass? What are some of the other tests you think that the doctors can go down and get a closer look to see?
You said a PET scan for cancers and
Yes, exactly. Yep, exactly. So a CAT scan is a good idea, an MRI, and then a patient to really see what this mass is could go down and get a bronchoscopy. And that's where they put a scope down through the tracheobronchial tree. And they could go down there and take a little chunk out of it and biopsy that. Okay, so these are all really good. So here's one nodule. There's multiple masses in this X-ray. Fine nodular, you guys can see them on both sides. Okay, oh, this is a good picture of atelectasis here. This is consolidation. Diffuse consolidation means it's all throughout both sides. And then multifocal, ill-defined just means there's some here, there's some up here, there's a little down here. So what I would do, you guys, is just keep practicing on these. I wouldn't mind showing you guys a good chest congestive heart failure. Okay, there. So do you guys, this is a good congestive heart failure because do you see how it's just radio opaque on both sides? And so this is pulmonary edema. And you see how you can't see anything besides a big lump here for the heart?
Mm-hmm.
Yeah, this is what we would call CHF. So it's congestive heart failure, and there's pulmonary edema from the heart itself. Okay, so this is kind of cool. There's a pacemaker here. Okay, you're seeing a full hilum. These little things are called curly bead lines, and that's just fluid coming out of all of the vascular spaces. Okay, and there's a large heart here, cardiomegaly. So I think chest X-rays and imaging are kind of fun because you're just looking at pictures of what's going inside in the chest. So that's a very basics on that. We'll continue to keep looking at these.